Anyway, so our next speaker is Helen Han. She's my colleague at USC, and she's assistant professor of medicine. She's the program director for the Advanced Hepatology Fellowship, and she's also the medical director of the Living Donor Program at USC. And she's going to be talking about or teaching us when we should refer patients for liver transplantation.
Okay. Thank you to the organizers for inviting me to talk to you all today. I'm just appreciative I'm not tomorrow because there is a World Cup game happening. Go Argentina, so I appreciate that. So I have, unfortunately, no financial disclosures. So for the next 25 minutes, I'll really be giving you some overview of the current allocation status for liver transplantation. And I'm really pleased that Dr. Durazo kind of set the tone for this discussion on organ shortage. I will highlight some of the reasons for the high waitlist mortality and bring to light really some of the newer paradigms that are in place to refer patients to transplant. And why living donor liver transplantation. I have to always get that in there. So the current allocation system really intends to direct livers to the sickest patients, really first by prioritizing them based on the model for end-stage liver disease, or the MELD score, as you all know. And it predicts 3-month survival. And you can see on the graph here that around the teens is when you start seeing that decrease in survival, mortality continuing to increase as your MELD climbs into the 20s, into the 30s, and a greater than 90% mortality once you hit a MELD of 40. And patients are sick. We have 12,000 patients waiting on the wait list for transplant, and this is data from the SRTR that summarizes the wait list outcomes at 3 years. And this graph really hasn't changed much. If you look at the recent data, if you look at the data prior to 2014, but 55% of patients waiting on the wait list are transplanted, whether by DDLT or LDLT, so deceased donor transplant or living donor transplant, as you can see in the turquoise lines as well as the mustard line. And 33% of patients are either being removed for being too sick or dying on the wait list, as you note in the green line or the pink line. And once they are transplanted, most patients are sicker. And you can see here, this is a map in the right upper corner of the US. And this is prior to February of 2020, when we were allocating organs by regions. And there are 11 regions in the US. We are region 5. And you can see on this graph here that when looking at those who are getting transplanted with MELDs of 35 and greater, Southern California had some of the sickest patients, and it really didn't change over time over that 4-year period. This also demonstrates how patients are getting sicker. Over a 6-year period, you can see the map on the very left that Southern California had median MELDs at transplant of 30 in 2012, and over 6 years, they only got sicker with a MELD of 35, and this is prior to even the change in the MELD scoring system to MELD sodium. And you would expect that with sicker patients in Southern California that our transplant rates would meet that demand, and it didn't. So we had some of the lowest transplant rates in the country, but the sickest patients at the time of transplant. So that kind of variability really existed, prior to the acuity circle policy changes in 2020. But this really demonstrated that organ demand really outpaces supply, and this shortage really leads to longer liver transplant wait times. This is a study that was presented at ATC in abstract form, and currently they have a publication in liver transplantation this year, but really demonstrating that livers are not equally distributed across the country, and this is what really prompted that change to acuity circle policy changes. But the map on the very left shows the median allocation MELD scores at the time of transplant really varying all across the country, from MELDs in the 20s all the way up into the 30s, and Southern California, again, being some of the darkest colors that you can see there in the very dark blue. After the acuity circle policy change in February of 2020, there's been some improvement in equity as far as distributing of organs, with variations in the median MELD at the time of transplant coming down from 13 to about 11. And our goal would really be that map on the very right, having a lot more equity in that distribution. And how are patients doing once they get transplanted with very high MELDs? Their graft survival is lower. So those who have MELDs of 40 and greater at the time of transplant, their graft is not surviving at the rates of someone who's transplanted with MELDs of less than 25 at 5 years. So how do we really bridge this gap of high demand, low supply? And one of the ways that I'm going to talk about is really by referring early and transplanting early. This graph shows over a 10-year period that the deceased donor transplant numbers have kind of stayed steady. From 2010 to about 2015, we're doing about 6,000 transplants a year. Now we've reached about 8,000 plus. The number of removals from the transplant list haven't really changed if you look at the 2010 numbers to the 2020 numbers. And living donor liver transplant has become more favorable in the past couple years. We've reached up to 6% of all transplants being living donor liver transplant. And we've really employed extended criteria, use of extended criteria livers. Dr. Durazo just mentioned nicely increasing use of DCD organs. Now surgeons are looking at fattier livers, older livers, and that's definitely one way in which we can increase our organ pool. Another way would be to consider living donor liver transplantation. So the older paradigm, and I did training about 12 years ago now, the mantra was, hey, someone has a MELD of 15, they may have some decompensation, refer the patient at that time for transplantation. If a patient presents with some complications of portal hypertension that would meet the MELD exception criteria, absolutely refer them to transplantation. And this is really based on data that patients with HCC, HPS that meet criteria, portal pulmonary hypertension, those who are requiring thoracentesis for their refractory hepatohydrothorax, these are all patients that have high rates of mortality on the wait list. And this is based on data from years ago. After MELD was put into place in 2002, Marion and his group looked at some modeling, or performed some modeling, and looked at what MELD would you start having that shift from risk of transplant being higher than benefits of just waiting on a wait list. And they really found that right at that 15 mark was when you had some benefit. And that's where, that's where we began to really practice that, refer patients at a MELD of 15. How about those who have decompensation? This is from a study published in 2006 that looked at survival at 5 years in patients who have compensated cirrhosis compared to decompensated cirrhosis. And of course, that median survival dramatically decreases when patients have decompensation. And then, those who have HCC and all these, again, complications of portal hypertension in cirrhotics, they end up having the high waitlist mortality, and those are the times that we would refer patients to transplant, to a transplant center. And if you look closely into the UNOS policies, the criteria is really strict. So even if you have a PSC patient who have cholangitis, you know they have cholangitis, they're coming in with fevers, they're not well, but they're not growing any bacteria in the blood. They may not make it to the ICU requiring pressors. They will not make MELD exception, but they're considered sicker than their MELD. So there are shortcomings to the MELD sodium. It underestimates the severity of illness, so particularly in those with autoimmune diseases, cholestatic diseases. The MELD sodium doesn't account for frailty and sarcopenia. It leads to gender inequity in allocation for transplant, and it does not predict post-transplant outcomes. So these are just 3 cases that I wanted to throw out there, and these are patients that you probably have in your own practices. A 29-year-old man with a history of Crohn's disease, PSC, and has cholangitic episodes. And again, as I mentioned, may not really be coming into the hospital, getting admitted. They may not be in the ICU, getting pressors and growing resistant organisms, which are what it takes to get MELD exception, but they're not well, and they fall into this criteria of patients who are sicker than their MELD. How about that woman who's 65, who has cirrhosis, NASH, and a lot of our NASH patients actually are frail, and they may have a calculated liver frailty index that's quite high. We do have our nutritionists in our clinics performing liver frailty indices by performing different maneuvers, whether it's a hand grip strength maneuver or a chair sit to stand maneuver, et cetera, to be able to calculate the index. How about that 52-year-old woman who has cirrhosis, maybe due to alcohol use disorder, and they have a T2 criteria meeting HCC, so they're within Milan, but they're just too decompensated. Their bilirubin's too high for treatment, and they have an unfavorable blood type for getting a transplant. These are patients who are stuck. So what is sort of the newer paradigm? So, we have to think about that frail patient. We have to think about that sarcopenic patient, where these are patients who have high waitlist mortality. What about that transfusion-free patient, Jehovah's Witness patient that comes into your office and you say, well, they're well compensated, they don't need to be referred to transplant. How about that patient with the HCC that may be too small or too large? They may be, not quite meeting Milan criteria, but outside Milan criteria. Should we be referring those patients at all? Women should be considered, or men even who are smaller. Maybe they're smaller in height, maybe they're frail. The advanced age patients, the cholestatic disease patients. And then how about those patients with particular malignancies that now are indicated for transplant? And I won't really go into this, but some of those patients who have intrahepatic cholangiocarcinoma or metastases from colorectal cancer, there are centers that are performing transplant in these patients. So talking about the frail and sarcopenic patients, I think it's worth spending a little bit of time on why these patients should be referred early. Frailty is found to have a prevalence of about 20 to 40, 50% in cirrhotics. I would say that that's even a larger prevalence than those, having ascites and variceal bleeding, et cetera. So this is very common in our cirrhotics. And when we talk about frailty, we're really talking about functional decline. We're talking about decreased physiologic reserve. And their vulnerability to health stressors. So Dr. Lai from UCSF has done a really beautiful work in the last few years looking at liver frailty, and has created a scoring system that I mentioned, the Liver Frailty Index, and that's been validated in the outpatient setting for cirrhotics. And if calculated to be above 4.4, then they have increased waitlist mortality and higher likelihood of delisting after adjusting for severity of liver disease from the waitlist. It's increased with age, and these patients need to be referred early. Sarcopenic patients, Prevalence is 40 to 70% in our cirrhotics. There have been data to show that if a patient has sarcopenia, which is formally defined as those having a cross-sectional imaging at the L3, if you look at the psoas muscle mass, having cutoffs if less than a particular number for men and women, they're considered sarcopenic. So it really addresses muscle mass and function. If you have a sarcopenic patient, it increases waitlist mortality, infection rates. It's associated with decline in pulmonary and functional status, and they have an increased post-transplant mortality. Shifting to transfusion-free patients. Transfusion-free patients are unique. Most of them, majority of them are Jehovah's Witnesses. And there's a misconception that these patients really should be referred when they're decompensated, similar to other patients. But we really need to capture them early. These patients have to have very specific laboratory goals, according to surgeons and the anesthesiologists, to be able to perform a transplant without any blood products. So INRs of less than 1.5, hemoglobins above 13, and platelets above 100. And we, as a program and many other transfusion-free programs, will augment these patients with Nplate, with EPO, et cetera. And post-transplant outcomes in the transfusion-free patients are excellent. So these are patients, if you see them in your practice, should be referred early when they're compensated to start having that discussion about future transplant. HCC patients. So it used to be that we had a patient that we would just send for transplant when they met Milan criteria or 2T criteria according to UNOS policies. But now we know that we can downstage these patients. Now we know that we can be aggressive and get them to Milan criteria at the time of transplant, and they would qualify for MELD exception. So these are patients that have excellent outcomes, those even beyond Milan criteria that get downstage. Those with small HCCs should be referred early as well, because we all know that HCC growth is really about the tumor biology. It's about the patient, it's about the tumor. So this just summarizes some of the UNOS policy changes that have occurred in the last few years, and that's even with patients who have AFPs above 1,000, as long as they're downstage and their AFPs are less than 500, they would meet eligibility for MELD exception. If they don't have AFPs less than 500, then they would not get the MELD exception points. UNOS has actually changed their policy where we now, when we have a patient who meets the T2 criteria, they receive MELD exception, they're approved, but they must wait at least 6 months before they have the activation of those MELD exception points. And that again reflects back on the idea that it's all about the tumor biology. If the tumor grows rapidly, invades a vessel, et cetera, then they would not be a transplant candidate. And then lastly, really, UNOS implemented this downstaging criteria that hadn't been in place years ago. And as long as they are downstage accordingly to the T2 criteria, they would make MELD exception. How about older patients? The data out there is inconsistent, and age has been shown to independently to frailty correlate to high waitlist mortality. But there are studies that actually show that as long as those who are older, so 70 and greater, have lower MELD scores. So independently, the age has been increased, been associated with increase of graft loss, but if their liver disease is pretty stable, their MELD score is less than 28, even 21, some of this subgroup analysis have shown, they do just as well as the younger patients. How about women? Women are 30% less likely to undergo transplant, and that disparity has increased with the introduction of the MELD in 2002, MELD sodium in 2018, and this is related to the size, muscle mass that correlates to decreased creatinines compared to men. Women tend to have cholestatic diseases or autoimmune diseases, And even with HCC MELD exception, they have decreased rates of receiving MELD exception, so they're at a disadvantage. So these are a population that you should really consider referring early to transplantation. The good news is there's been updates to the MELD, and I will say that in 2021, the MELD 3.0, there was a study that was done by Ray Kim and his Stanford group that incorporated some extra variables such as female gender as well as albumin. And that has actually improved or increased MELD for women, and it's accounted for how their creatinine can be a little bit lower. And they've shown that after 3.0 was compared to MELD sodium in the SRTR database, that 10% or 9% of patients were recalculated to have a higher MELD amongst the women. So this has actually been approved by UNOS in June, and I think you should be learning a little bit more about this as the months come along. So I want to finish with why living donor liver transplantation. I showed you how we could, one of the strategies in which we tried to really close that gap of high demand and low supply. And Dr. Durazo mentioned some of the, normothermic reperfusion machines that are being employed in DCD, and really trying to utilize methods to not discard organs. But another way is living donor liver transplantation. And a consortium that was created many years ago that included 12 centers, the A2ALL, or Adult to Adult Living Donor Liver Transplant Consortium, have studied this extensively, that living donor liver transplant has a survival benefit whether your MELD is low or high. And they did this study looking at 868 patients, following them over median years of 4.6 years. And they found, when compared to those waiting on the wait list for DDLT, LDLT, whether the MELD was greater than 15 or lower than 15, did better as far as survival compared to those waiting. And overall, LDLT recipients had 56% lower mortality with a hazard ratio of 0.44. When looking at long-term data, 10-year follow-up, and we've seen this in 20-year follow-up as well as on a global scale, that patient and graft survival are comparable between LDLT compared to DDLT. And this was a study by the A2ALL group, again, looking at over 900 LDLT patients compared to 464 DDLT patients over a 10-year period, and only including centers that had performed at least 20 LDLTs. And when adjusting for MELD, age, etiology of liver disease, et cetera, that they had comparable mortality and graft failure in the LDLT group compared to DDLT group. And who benefits the most? Who do better? As far as the multivariate analysis for mortality, it was women who did better, and those with PSC. For graft failure or graft survival who did better, those with autoimmune diseases like PSC and autoimmune hepatitis. How about healthcare costs? Shorter hospital stays, less healthcare costs were found in a study that was done by the UPMC group, who do about 70 LDLTs a year. They compared 60 LDLTs to DDLTs, around 52 patients, and they looked at 6 months pre-transplant and then up to over a year after transplant. And there were less outpatient labs being performed, less radiology scans, ER visits, GI procedures. So really, patients are being transplanted at lower MELDs and they're doing well, so they're having less hospitalizations. But utilization of LDLT worldwide really differs, and you can see in this map here, when you look at the number of LDLTs on the y-axis and the different countries and continents on the x-axis, you see that in the US we're doing about 6% LDLT out of all transplants, where in Asia it's 95%. And Canada really has a mix, so utilization all across the world is quite different. So I want to conclude by sharing some of the take-home points. So MELD sodium does not always capture true severity of illness. But we need to really go beyond the older paradigm. We need to think about frailty. We need to think about sarcopenic patients. We have to be mindful of referring patients if they're transfusion-free, if they're maybe a smaller patient. Perhaps they will be disadvantaged by the MELD score, and hopefully the 3.0 will be helpful to them. Those who have small HCC not meeting Milan criteria, we should get on top of that and refer them early. Those who are outside Milan and have no extrahepatic disease, we should really think about still advocating for them and thinking about how we can downstage them to get to transplant. And then older patients, really thinking about them in a different way, and refer early to liver transplantation and consider living donor liver transplantation. Thank you.